started, I should tell you it's a real honor to be able to introduce Dr. Kathy Sanders-Phillips. She is a professor of pediatrics at Howard University's College of Medicine, and she also holds an adjunct professor position in the Department of Pediatrics at George Washington's University Department of Pediatrics and the Children's Hospital. So Dr. Phillips' research focuses on the impact of social structures and inequalities on health outcomes and behavior in communities of color in both the United States and abroad. She really has an incredible wealth of experience on health disparities and has been doing this type of work for a number of years. At Howard University, Dr. Sanders-Phillips founded and served as the director of the research program in the epidemiology and prevention of drug abuse and AIDS. And the purpose of this program was to conduct research on health disparities both in the United States and South Africa. So she received a grant from the National Institute on Drug Abuse, which served as the foundation for this work. And as part of her research on health disparities, she's really devoted an incredible amount of time to mentoring underrepresented ethnic and racial minority scholars in the conduct of research. So that's one of the major roles she has fulfilled at Howard University. Dr. Sanders-Phillips holds a Ph.D. in developmental psychology from the Johns Hopkins University, and she completed her internship in pediatric psychology at the University of Maryland Hospital. Prior to joining the Howard faculty, she actually had connections here at UCLA, both in the College of Medicine. She was also faculty at Charles Drew University. Dr. Sanders-Phillips is an extremely well-published author. She's had numerous publications on health disparities in communities of color with a particular emphasis on the influence of the exposure of violence on psychological distress and health behaviors. She has served on many scientific review groups at NIH and CDC, and she's also served as a member of the National Advisory Council for NIDA. So I just want to welcome her, and we're looking forward to her presentation. So thank you.
I'm going to put this on, and I want to say, first of all, well, good morning, good afternoon, and thank you all for giving me an excuse to leave Washington, D.C. yesterday morning. I got out right before the storm. I have to tell you, and we're going to go on a little bit of a journey today. I'm at the point in my career where I have the luxury of looking back and reflecting on how I got to where I am and the important moments in my life that took me to particular places, and that's part of what I'm going to be sharing with you today. But I will say that although I had a very compelling offer that took me to Washington, D.C., it has never really been home. Los Angeles and California will always be home for me, so I am also equally grateful to have an opportunity to come back and visit my old stomping grounds. I had an early experience in DC where I was delighted, feeling homesick for LA, to see a Trader Joe's early in the time I had moved there, and I was cooking something and I needed wine for the recipe, so I went to Trader Joe's and went up and down the aisles and couldn't find any wine. And I went up and down again, and then I went to the manager and I said politely, "Where's the wine?" He said, "We don't sell wine." I said, no, where's the wine? And he said, "We're not allowed to sell wine." And I said, "No, you don't understand. By definition, if Trader Joe's doesn't have anything else, it has wine." And so you cannot be at Trader Joe's. And I knew then, I said, I'm in major trouble. This is a mistake. I should not be on the East Coast. So thank you for bringing me back to California and to Rouse. I'm going to be talking to you today about HIV risk in South Africa and the implications of studies that we've conducted in South Africa for HIV research in the United States. But I want to, as I said, I want to take you on a conceptual journey of how I came to be the researcher that I am, how the studies that I've conducted came to be, and what I think the implications are for our understanding of how to address HIV/AIDS more effectively here in the United States. So the beginning of my story was here at UCLA. I was an assistant professor in the Department of Pediatrics, also in the Department of Pediatrics at the King Drew Medical Center. As a developmental psychologist at Johns Hopkins, my primary interest was in infant development. I was absolutely amazed by the capacity of the human infant and the degree to which we really understood basic functioning of our species by looking at the skills and behavioral repertoire of the human infant. It was my interest then in infant development that brought me into the arena of drug abuse, rather than vice versa, because I was coming of age as a research scientist at a time when women were beginning to use drugs prenatally in numbers that we had never seen. And as an infant development specialist, my goal was to begin to understand how this prenatal drug exposure might impact infant development, both in the short term as well as the long term, as well as issues such as infant attachment, mother-infant attachment. So it was this mindset that brought me to UCLA, to King Drew Medical Center, and to begin a relationship with Dr. Arthur Parmalee, who many of you may not know, but he was one of the godfathers of infant development and infant research at that time. My second set of experiences occurred primarily in Compton and Watts, and hence my bullet point here of Watts, Guns, and Kids. It was during my experience in Watts at the King Drew Medical Center that I became aware of the overwhelming number of children who were coming through pediatrics with gunshot wounds. I was amazed, because this was a phenomena that most of us had not seen. Probably for many of you in your generation, this is not unusual, but in the late 70s, the early 80s, we had not seen children with gunshot wounds. We had no concept of how both the exposure to violence that they were seeing in their communities, as well as having to think about losing your own life during childhood, impacts the trajectory of childhood. What does that mean? We were beginning to understand that there were both psychological effects, and through some of the work done here at UCLA and other places, there were also biological effects of growing up under circumstances of chronic violence exposure and stress. So that began to set the stage for how do we understand this? What are the connections? Are there connections between growing up, living in a community of violence, and, for example, the drug use that we're seeing in women that subsequently impacts infant development? Then I endured what I called the trial by tenure and by the UC AIDS task force here at UCLA. At that time, the chair of pediatrics was Bill Friedman, who was a wonderful, wonderful man. And he brought me into his office, and he said, "Kathy, it is time." And I, in my naivete, said, "Time for what?" And he said, "Time for tenure review." Being most of my time at King Drew Medical Center, I had not been well prepared for tenure review, and came close to a dead faint when Bill Friedman informed me that I had 15 articles I needed to get published. I had 2 at the time, and I had a year to do it. And he looked at me, and his last words were, "I suggest that you get to writing." As I wrote and I did get the 13 articles published in a year. I came up before the review committee. Of course, I wasn't there in person. I understand, though, from stories I've been told, that Bill Friedman was. And there was a big discussion in the tenure review committee about the fact that I was not a traditional scientist, meaning I did not focus primarily on a specific area of expertise. And when Dr. Friedman talked to me about this, he said, Kathy, you're breaking the mold. You're conducting research across many different areas. That's hard for the tenure committee to understand. And I said, Dr. Friedman, part of what I have come to know is that I am a scientist who is defined by a population, not a specific discipline. Meaning that I am a scientist whose primary goal is to improve health outcomes, largely in communities of color. From that perspective, I am perfectly willing to look at economic factors, political factors, psychological factors, biological factors, any group of factors that impact health outcomes. And the failure to do so would essentially be unethical. And he said, then explain that to the committee, and we'll see where it goes. I later learned two things. Number one, that conversation started my journey of defining myself and asking the question of who am I as a researcher, particularly a researcher of color. And secondly, that when the discussion came up again in the tenure review committee, Dr. Friedman, for those of you who don't know him, probably weighed about 300 pounds. He was a big man. But I understand he reared back on his chair and looked at every member of the committee and said, give this woman her tenure. And they did. They did. Despite the fact that I did not fit the traditional mold of a UCLA researcher. So the next chapter started with the UC AIDS Task Force. I was appointed to the UC AIDS Task Force, which I think still exists, that was created towards the beginning of the AIDS epidemic to allocate funds, UC funds, to investigators for HIV/AIDS. I was brought in dragging and screaming because I was a drug abuse researcher. I didn't have plans to look at HIV/AIDS, but it became clear that the two were entwined. And I needed to address the interface between drug abuse and HIV/AIDS. I will never forget my first UC AIDS Task Force meeting in San Francisco, where we got to the portion of the meeting where the community was allowed in. The double doors to the meeting room opened. ACT UP walked in. I didn't know who ACT UP was. I had never seen them before. I see this group of men walk in black boots, combat boots, and steel on their arms. And again, I asked myself, what am I doing and who am I as a researcher? But it was a breakthrough moment for me in understanding that the AIDS epidemic would not be solved with a pill, that it was a complex health problem that would demand the attention of social scientists, clinical scientists, and basic scientists to solve the problem. The next chapter was Jonathan Mann. For those of you who may not know Jonathan Mann, he was an AIDS researcher and activist out of Harvard. I had the pleasure of hearing him speak not long before he was on a Swiss Air flight to the World Health Organization, and the plane crashed and Jonathan Mann was killed. But in a lecture similar to this, he looked at an audience of some of the most esteemed scientists in the United States in HIV/AIDS. And what he said was, I'm not going to talk about the statistics regarding AIDS. Everybody here knows it. And it's not the statistics that are important. What is important is your understanding of the social foundations and context in which a disease like AIDS operates, in which a disease like AIDS exists and is maintained. It requires a social framework and context to continue. And he said that one of the most important lessons that an AIDS researcher could learn is that it doesn't matter where AIDS enters a country, where it will always settle is in the groups who are least deprived of their rights in that society. Members of secondary social groups, those who experience social inequality. And he was the first to introduce me to the importance of that interface between health and human rights. And they're inextricably linked, and we will not solve a problem like AIDS without addressing the human rights violations that give rise to it. So with that in mind, I'm going to take you on a conceptual journey via two studies that I've conducted in two countries, the United States and South Africa, that I think support the words that Jonathan Mann left in my mind and that substantially impacted my career after meeting him. The first is the impact of exposure to violence and historical trauma on drug use and AIDS-related risk behaviors among adult women in South Africa. And I'm going to go through the data portion of this pretty quickly. I think we have time for questions afterwards. This was a study that I developed to examine relationships and assess the degree to which exposure to violence, historical trauma, and current discrimination may be risk factors for psychological distress, substance use, decreased AIDS prevention knowledge, and AIDS risk behaviors in a sample of South African women. It's important to note that this was one of the first studies in South Africa to specifically examine current and historical exposure to racial discrimination, and to define racial discrimination, both historical racial discrimination, which was apartheid, and current discrimination, which continues to exist in South Africa, to define those social experiences as a form of social violence that may impact health risk behaviors in ways that are similar to the impact of violence exposure in other contexts. In other words, we know that exposure to violence in other contexts, in the home, interpersonal, in the school, in your community, we know that that is associated with an increased likelihood of risk behaviors. What we did not know, particularly in a country like South Africa, was whether or not exposure to racial discrimination historically and currently would operate in the same way relative to its impact on health outcomes and risk behaviors. Our subjects were all women. They were recruited from medical clinics in Cape Town, South Africa, and administered surveys in their language of choice in one-on-one interviews conducted by interviewers who were matched by gender, ethnicity, and language. We used two sets of surveys, those that we found from the literature in South Africa, which were fairly limited. Others from US studies we had to adapt for a South Africa population. Very quickly, we looked at demographic data, psychological functioning, including depression, hopelessness, self-esteem, perceptions of total stress, exposure to violence in their homes and communities, their experiences of historical trauma, which is effectively apartheid, and their emotional responses to apartheid, their current experiences of racial and gender discrimination and their emotional responses to these events, alcohol, tobacco, and other drug abuse, AIDS prevention knowledge, their frequency of condom use, attitudes towards condom use, perceived sexual relationship power and perceived confidence in using a condom, and their sexual risk-taking behaviors, including whether they had multiple partners in anal sex. These quickly are the demographics. I want to simply point out to you that in a socially stratified society like South Africa, and I will later make the point, the United States, people are primarily identified by their racial and ethnic group. South Africa developed a system that had 7 classifications of racial and of racial identity, with whites at the top, blacks at the bottom. There were multiple levels of what they considered coloreds or mixed race people. However, when I did this study, my colleagues in South Africa were black and colored. And it's important to understand and always to honor the culture of the country that you are involved in. The use of the words coloreds and blacks can be offensive to coloreds and blacks in South Africa. So they asked that we refer to our groups as Afrikaans speaking, which is the predominant language of the coloreds, and Xhosa speaking, which is a predominant language of the blacks. You'll see there were some differences in age, marital status. The notion of whether or not you own a house in South Africa is critically important, a critical predictor of socioeconomic status, even though the house that you own, if you are black or colored, is often made of cardboard walls with a corrugated roof. And we were also interested in who they lived with, because many, many young women in South Africa continue to live with their parents. In general, what we found was that in terms of demographics, Afrikaans-speaking women or coloreds had 2.3. Children, Xhosa-speaking women, blacks had 1.6, and I will give you a warning. These findings will probably challenge some of your preconceived notions about what we might have expected in terms of differences between the black and colored women. Given that colored women and coloreds in general in South Africa were placed legally at a higher level than blacks, blacks were the lowest, which means that they had a privileged position in the social hierarchy. They did not have the rights and privileges of whites, but they had considerably more than Asians and blacks. One might assume that that would provide some kind of protective psychological function. I think you'll see that that does not seem to be the case. More Xhosa-speaking women considered themselves not religious. Xhosa-speaking women were more likely to have finished high school, and more than 80% were unemployed and earned less than 1,000 Rand a month. I don't know what the current exchange is, but that's somewhere around $100 a month. In terms of their substance use, you see higher numbers of Afrikaans-speaking women were using cigarettes, daga, which is their word for marijuana. Low but higher in Afrikaans-speaking. Afrikaans women more likely to be using illegal drugs. And they have home brews in South Africa. The constitution of the home brew, I don't know if anybody here is from South Africa. I got different answers depending on who I talked to. It ranged from a kind of beer-like concoction to actually some kids would go out into the fields and collect cow dung and smoke it. So I'm not entirely sure what homebrew is to this day, but Xhosa-speaking women were more likely to be utilizing it. So we conducted multiple regression analysis to identify the significant predictors of alcohol use. And again, I'll go through these quickly. It's a pattern that very quickly developed. Exposure to community violence predicted higher alcohol use. Exposure to home violence predicted higher alcohol use. Exposure to gender discrimination predicted higher alcohol use. And exposure to racial discrimination predicted higher alcohol use. We looked at the predictors of daga and other illegal drugs. As I said, the rates were very low, so it was a very small N. 8% of Afrikaans women were using some kind of illegal drug, 2% Xhosa women. So I'm not surprised that we didn't get significance, but there was a trend for exposure to community violence to predict illegal drug use. In terms of tobacco use, Afrikaans-speaking women were more likely to be using tobacco. Tobacco use was, again, predicted by exposure to community violence, exposure to gender discrimination, and in this case, not their level of exposure to racial discrimination, but their emotional reaction to racial discrimination. In terms of HIV risk, I've gone through the outcome measures. You see that the sample frequencies, some of them are quite disturbing. 89% of Afrikaans-speaking women were below the cutoff for low levels of knowledge regarding HIV prevention, but 71%, so you're talking about the overwhelming majority of these women were relatively uneducated about HIV prevention. However, significant difference in the Xhosa women feeling much more confidence in using a condom. Alternatively, the Afrikaans-speaking women were much more likely to be engaging in risky behaviors, never using a condom with a spouse, never using a condom with a casual sex partner. The opposite, Xhosa women more likely to feel like they had higher sexual power. In terms of condom use with the multiple regression analyses, Xhosa women were more likely to report condom use with a regular partner. And again, any measure that we used of condom use, exposure to community violence, exposure to violence in the home, gender discrimination, and racial discrimination predicted lower condom use. Same pattern with predictors of the ability, their perceived ability to use condoms. Again, Xhosa women more likely to feel confident, but their exposure to community violence, violence in the home, gender discrimination, racial discrimination, and in this case, direct emotional responses to historical trauma of apartheid predicted condom use. Perceived sexual power, community violence exposure, predicted power, perceived power, emotional responses to historical trauma, apartheid predicted perceived power. AIDS prevention knowledge, Xhosa-speaking women more knowledgeable. Most of the predictors of violence exposure predicted lower knowledge of HIV prevention. We then looked at the psychological predictors of condom use. We found, as you might expect, higher depression, higher hopelessness, and low self-esteem all predicted less favorable attitudes towards condom use. If a woman reported perceptions of high stress, she tended to report lower confidence in her ability to use condoms. Higher depression, higher hopelessness, low self-esteem predicted less perceived power in sexual relationships. Drug use, tobacco use predicted frequency of condom use. I'm still kind of thinking about that one. I'm not quite sure why that particular one came to be. Tobacco use predicted less favorable attitudes about condom use. Tobacco use and alcohol use were correlated significantly. Tobacco use predicted less perceived power, and alcohol use predicted less perceived power in sexual relationships. I think what you're seeing here is the overall and more generalized effect of drug use. That drug use, when a woman is pushed into drug use, it is often because there is psychological distress in her life, that she is feeling less power, less control, more hopeless. So what were our conclusions from study 1? Drug use and HIV/AIDS risks exist and must be understood in the context of current social experiences as well as historical trauma in some populations. These conclusions, in conjunction with previous findings regarding the intergenerational transmission of historical trauma, led our team to examine these relationships in South African youth. And I'm referring here specifically to the studies that were done in the 40s and the 50s, who looked at Jewish parents who had been in the death camps. Obviously, there were high levels of psychological distress in the parents, but studies were conducted of their children who had not been in the death camps. But to the surprise of researchers at that time, there were extremely high levels of psychological distress and dysfunction in the children of parents who had experienced that kind of historical trauma. This phenomena had not been examined in South Africa, and that constitutes our study too. Exposure to political violence, which is a term that I use often for apartheid and racial discrimination because it is less volatile. but racial discrimination is a form when you utilize political systems to enforce racial discrimination. When you use legal systems to enforce racial discrimination, you are engaging in a form of political violence. So this study was titled Exposure to Political Violence and Youth Risk Behaviors in South African Adolescents. And we are literally, as we speak, I was talking to my statistician last night on the phone. We are analyzing these data now. So please, if there are statisticians in the audience, don't kill me. These are preliminary. We're still working on massaging this data set. But the goal is to examine the independent and cumulative impact of exposure to multiple forms of violence, home, community, school, political, on drug use and HIV, AIDS risk behaviors in South African youth who had not been directly exposed to the political violence of apartheid. We again had surveys that assessed exposure to multiple forms of violence. We assessed psychological functioning, depression, anxiety, hopelessness, perceptions of stress. And because one of my partners on this study from the US is Wendy Cleaver, who is a professor of psychology and chair of the Department of Psychology at Virginia Commonwealth, and her area is emotional regulation. Wendy worked on this study with me, and we did look at measures of emotional regulation. We conducted our study, we piggybacked on the third annual Youth Risk Behavior Survey that was conducted in South Africa. South Africa is the only place on the continent of Africa, where the Youth Risk Behavior Survey is conducted. We did, as I say, look at emotional regulation, and in order for you to understand some of the findings I'm going to be presenting, I needed to make sure you understood that anger dysregulation expression is defined as a hostile behavioral pattern that is associated with hostile behaviors in social situations and a tendency to assess a situation as anger-provoking. Now, I'm not going to be talking so much about the psychological side today, but I want you to, as we go through these findings, to keep in mind that we're talking primarily about drug use and HIV/AIDS today. But I want you to keep in mind the implications of these findings for violence that we see in communities like South Africa and the United States, that violence that we often see that's perpetrated by males against females, and how that may be related to some of the findings that we report in this study. It's based on our analysis. We had 1,574 youth in high schools in the Western Cape. We used multiple and logistic regression. So again, replication of our earlier findings. Exposure to violence in the home predicted higher psychological distress and that anger dysregulation. So kids who are exposed to violence in the home are more likely to not only be depressed, but to project anger on others in the community. Exposure to violence in the home increased the odds of smoking and other drug use. Not alcohol use during sex, interestingly. Exposure to violence in the home associated with a higher number of sexual partners, lower chance of using condoms. Violence in schools is very high in South Africa. I think some of you may have heard about it with some of the problems that Oprah Winfrey ran into in establishing her school in South Africa. So we looked at violence at school. It was associated with depression, anger, anxiety, perceived stress, not with self-efficacy and hopelessness. It was also associated with higher odds of drinking, smoking, and marijuana use, and with a higher number of sex partners and less chance of using a condom. This was, of course, the one I was most interested in. Political violence was associated with all measures of psychological functioning except perceived stress. Now keep in mind, you're talking about children who were not directly exposed. These kids were born after 1994, which was the technical end of apartheid. But some of them, particularly if they were older, were living with parents where police came in the middle of the night and took your parents and you didn't see them again. And they were living with parents where they may have not seen this happen, but it did happen to the parents. And of course, the parents carry that trauma with them, which subsequently is likely to impact their parenting behavior. Exposure to political violence was also associated with a higher number of sex partners. We also looked at cumulative exposure. I'm not going to spend a lot of time here, but as you might expect, the more children are exposed to violence across contexts, in their homes, in their communities, in their schools, the more likely you are to see dysfunction of some sort. So this is associated with greater psychological distress, a greater likelihood of drinking, smoking, marijuana use, and a higher number of sexual partners and not using a condom. So the question I was interested in is, if cumulative violence exposure is important, if we not only need to be looking at how often or frequently a child is being exposed, but how many contexts a child is being exposed in, does something unique, does political violence play a unique role? Does it potentially mediate or moderate these relationships? We found that political violence, exposure to political violence, exacerbates the effects of exposure to school violence, of lifetime community witnessing violence, of lifetime community violence direct victimization, on anger inhibition. So if the child reported exposure to political violence, exposure to any of these other measures of violence, in addition reported exposure to political violence, it seemed to incapacitate or decrease their ability to control their anger. And I have to say, after years of trips to South Africa, you see this. The anger is palpable. And we're looking at some of the sources of it. Exposure to political violence exacerbates the effects of lifetime community violence direct victimization, exacerbates the effects of lifetime community violence witnessing, lifetime community violence victimization on anger regulation coping. And the only one that we have so far in terms of a direct impact on risk behaviors is on smoking in the last 30 days. The others were not significant, but I have a hypothesis about why that's the case. So what are our conclusions from study 2? Cumulative exposure to violence in multiple contexts significantly influences psychological functioning, drug use, and AIDS risk behaviors in South African youth. The cumulative impact of exposure across a number of contexts is associated with higher levels of psychological distress, greater drug use, and more sexual risk-taking. However, political violence, i.e. historical apartheid, current political racial discrimination, continues to influence outcomes in South African youth who did not directly experience apartheid. However, we are beginning to understand, and we will continue our analysis, but at this point it seems that the primary impact of exposure to political violence is on psychological distress. And in turn, it is the high levels of psychological distress that are associated with the risk-taking, the not using condoms, multiple sex partners, and drug use. That, by the way, parallels findings that we have collected here in the United States. So the lessons from South Africa: risk behaviors, even at the individual level, are influenced by and reflect the social inequalities that exist in societies that are stratified by race, ethnicity, gender, and income. Thus, the context in which risk behaviors developed and are maintained must be addressed in any comprehensive HIV/AIDS prevention programs. Interventions at the individual level, while important, and I don't dismiss the importance of them, may not, however, sufficiently address the complex array of structural and social factors that influence AIDS risks. To promote significant changes in health outcomes, individual interventions must be accompanied by interventions at the structural and systemic level, at the political level, the economic level, the legal levels, particularly in stratified societies. Structural levels Our structural level interventions, if you're going to try to intervene at the level of political systems, economic systems, they mandate the collaboration of multiple disciplines and transdisciplinary research, which is now, in large part due to our colleagues down at UC Irvine, referred to as team science, meaning the collaboration across disciplines and stakeholders to address a complex health problem. Lewin actually, as far back in 1951, was among the first to promote the concept of action research that highlights the scientific and societal value of translating psychological research into community problem-solving strategies. Implicit in Lewin's formulation is the importance of achieving effective collaboration across disciplines and stakeholders, including community members and policymakers, to address complex social problems. Almost 70 years after Lewin made this observation, the emergence of the HIV pandemic, more probably than any other infectious disease, perhaps other than polio, has resulted in greater recognition of the need for collaboration across disciplines to meet the demands for effective prevention and treatment. In 2003, NIH issued the NIH Roadmap for Medical Research, and they specifically stipulated that transdisciplinary health research was identified as a major initiative to achieve the vision for research teams of the future as articulated in the National Institutes of Health Roadmap for Medical Research. Specifically, transdisciplinary training is a major strategy to address the need for scientists who can integrate diverse scientific approaches and work in transdisciplinary teams to solve complex health problems. So if that is the road that we need to take to comprehensively address HIV/AIDS in the United States and worldwide, there are implications. There are implications for the type of studies we conduct in the future, for the way we conduct research training, for the peer review system and who's awarded grants in this country, and implications for policy. And I'm going to go through these briefly. Implications for how we conduct research in the United States regarding HIV/AIDS. As I said, while definitions differ, team science draws on diverse disciplinary perspectives for the purpose of better understanding and ultimately resolving urgent public health problems effectively and efficiently. The degree of complexity of a given problem influences the breadth and the degree of cross-disciplinary knowledge that you need to solve that problem. For example, and we've proceeded along these lines, our findings in terms of studies, I'm going to be sharing with you quickly in a minute, our findings as well as those of other researchers reinforce the importance of developing HIV/AIDS prevention and intervention programs that acknowledge and address the impact of structural, systemic issues such as social inequalities, income inequalities, racial discrimination, and political violence. I urge you to think about the issues of voter suppression and voter rights that we're seeing in this country and the potential connections between that and health outcomes and the decisions that people make about their lives and their health in the United States and beyond. Achievement of the NIH goal of transdisciplinary research will require the collaboration and conduct of research that includes investigators from the social, basic clinical sciences, as well as representatives from the legal profession, economics, political science, and other social science disciplines such as medical anthropology, sociology, and demography. Given the international impact of AIDS, I think it's going to be particularly important that we develop, as I have done, cross-national, international teams to address AIDS research from a transdisciplinary perspective. In terms of what we've done, we've replicated with a US sample the findings from our South Africa studies. The impact of racial discrimination on AIDS risk behaviors and drug use in US citizens, African Americans, is just as compelling in our findings as we saw in the in the South Africa sample. We found that exposure to violence, including racial discrimination, predicts psychological distress, particularly symptoms of post-traumatic stress, and I'll talk about that in a minute, and subsequent risk-taking. Exposure, I literally just got this finding last week. We have looked at exposure to law enforcement as another form of violence in this community that is rarely examined in scientific studies. And to my knowledge, we now have the first data set to show that interactions with police, law enforcement, also predict psychological distress and risk-taking in African American, particularly African American men. We're also exploring the biological and psychological pathways and mechanisms by which exposure to violence and oppression influence risk behaviors. This work is based in part on animal studies. They've done some fabulous animal studies at Wake Forest where they've looked at how monkeys who are socially stratified and then are given access to illegal drugs. Both groups use them now. Both the dominant and the subordinates use them. However, what's interesting is it's the subordinates who become addicted. And the addiction is based in large part on the impact of social stratification on dopamine function. Now, I can't go a lot farther than that, but I was fascinated when I heard the study and knew that there were applications of it to human stratification. We also are looking at genetic factors and how they may mediate relationships between violence exposure and health outcomes and risks. We're also focused on identifying strategies for fostering resiliency that include family-focused interventions, which is Wendy Cleaver's area, but as well looking at social justice interventions. And in collaborations with colleagues from health law, we are, such as Burris up at University of Pennsylvania, we've begun to examine access to health and health equity as a legal and political right that can be regulated by law and policy. So it speaks to the fact that health in this country and others is not simply a function of helping people adjust their individual behavior, but we may in fact have to have legal remedies that directly address the right to health and access to health resources as a U.S. citizen. There are going to be, I recognize, and probably you as well, implications of pushing for team science, for peer review and funding. It's going to present challenges to our current system of peer review. We need to begin to ask ourselves, how can the grant review process be enhanced to facilitate more rapid progress towards transdisciplinary team research and to accommodate and sustain the complexity of team science? I think there are potentially things we can do in the short term and the long term. We can increase the number of reviewers with expertise in structural factors related to disease and health outcomes. We can increase the number of reviewers with expertise in training specifically in team science. We tend to have very few reviewers on NIH panels who are really comfortable with transdisciplinary research. We need to increase the diversity of disciplines in peer review. I rarely see medical anthropologists, medical sociologists, demographers, economists who could make significant contributions, but they tend not to be on review committees. We need to provide much better education for peer review groups regarding the importance of team science and the need to support projects that challenge the existing paradigms of health in secondary social groups in socially stratified societies. We tend to have an overwhelming bias to see and evaluate members of secondary social groups using a deficit model. That is not always appropriate, and it does not always lead us to solutions that are effective. We need to provide better education for current peer groups on the need for projects that explore structural interventions, even though, yes, they're more complex. Yes, they may be less likely to succeed in the short term and be costly. But that cannot be the rationale for not conducting them. We also need to be much more aware and foster a greater awareness of the biases that can and do exist in our peer review system. They include the bias that health outcomes are primarily a function of individual behavior and not of the larger social system that dictates where you live and where you're educated and the access you have to medical care. And the bias towards using one ethnic group as the standard against which another ethnic group is judged. We had that problem when I submitted the South Africa grant, which was funded by NIH. So US reviewers were asking, why was I not including a white population? And I was really astounded. Why, if I am trying to understand the impact of apartheid, which was a legal system that directly affected black and colored, would I look at the impact of that legal system which favored the white population? That is not a scientifically valid approach. That makes no sense. And I was ultimately able, but I was surprised that even in this day and age, given a system as drastic as apartheid, that we would judge the reactions of blacks and coloreds against whites who had access to all the rights in that system. How do we create new models of transdisciplinary funding to develop methodological approaches across fields? In some, and I realize these are big issues, but you know, I got 10 years probably to retirement. I can leave it all in your laps. So I can go big or go home. Ultimately, we are going to have to grapple with how do we promote a better understanding of the fundamental structure and culture in which science is conducted in this country, and the demands for decisions that are driven by creativity. We do have to address whether our current system, as good as it may be, of conducting science in this country ultimately leads us to the most effective and creative solutions for health problems. Achieving the goal of transdisciplinary science also will require greater attention to how current award mechanisms are assessed, identification of new award mechanisms that foster the development of transdisciplinary science. And we're also going to need, assuming we can get people funded, we're going to need the cooperation and education of journal editors' review boards, because assuming you can get funded, you often then have trouble in getting these kind of findings published. So we will need input from that area as well. In terms of research training, for many of you who may be sitting in the audience, training is critical to the continuation of transdisciplinary science. If we don't focus on the next generation of investigators who are comfortable with transdisciplinary approaches in HIV/AIDS, we're not going to be able to sustain transdisciplinary science. So how do we develop the pool of emerging transdisciplinary scientists and identify models to guide their training? How do we evaluate their success and their career trajectories when they find that, like me, that career trajectory may be much slower climb up the academic ladder? If you break the mold, you may not get as many publications, or it takes you longer. How do we help prepare investigators for this reality? The training of transdisciplinary science is distinct in its intention to specifically develop scientists who synthesize the theoretical and methodologic approaches of different disciplines. As a result, I believe strongly that transdisciplinary scientists are going to be better prepared to be able to really address the complexity of health problems like HIV/AIDS. They're going to be better prepared to address some of the methodological issues and challenges that other scientists may not encounter, like what is an appropriate comparison group if you're looking at something like racial discrimination. I remember one reviewer said to me in my study on racial discrimination in the US, well, what is your control group? you need to find a group of African Americans who've never experienced racial discrimination. I laughed. I'm like, where's that? What planet are we going to get that from? That's not the appropriate comparison group, and it is not. It's not possible to recruit that, nor is it possible. One other example, I was saying, well, in order to establish causality, you would have to look at racial discrimination from the beginning. And my response to that was, well, let me see. At what point do we begin? Do we begin when an African mother has a child in utero and she can't access prenatal care? Do we begin at the point where her baby is born low birth weight and premature? Exactly at what point would you like for me to be able to not only examine and evaluate, but determine when racial discrimination begins to have an effect? I did get around those challenges, but they're real. They're real. I love to see things now as a reviewer, like greater utilization of previously not used techniques, or at least not used as frequently, like network analysis, to really understand how a problem is extending throughout a community. And you need to know that efforts are currently in place at UC Irvine, I think maybe University of Chicago or Pennsylvania, I can't remember now, to identify best practices and methods for promoting research training in transdisciplinary science. Lastly, there are going to be impacts of transdisciplinary team science for policy development. It's going to require, as I've said, the collaboration and support of all stakeholders who are impacted by the AIDS epidemic. Collaborative partnerships, lines of communications have to be forged between scientists and policymakers. An article that we wrote that's coming out in 2014 March in the Journal of Social Issues presents our findings that were very frightening, really, to me, where we discovered that African American youth who report high levels of racial discrimination also report symptoms of post-traumatic stress that in turn are correlated with higher drug use. We argue that these findings underscore the absolute need for structural interventions. We do have to do something about interactions between our youth and law enforcement in this country. And I specifically talked in that article about the impact of things like stand your ground laws on marginalizing and isolating African American youth who then begin to engage in risky behaviors. In closing, let me say the World Health Organization defines health policy as decisions, plans, and actions that are undertaken to achieve health goals in a society. An explicit health policy can define a vision for the future, help to establish targets, and it outlines priorities and builds consensus. This definition emphasizes the importance of identifying the primary factors that impact a given health outcome in a specific population, the prioritized targets, and the prevention approaches and interventions that are likely to be efficacious. Based on our studies and a growing body of data, meeting the goals of successful public health policies and programs regarding HIV/AIDS will require the support and assistance of other social systems and institutions such as the legal system, educational and law enforcement systems to successfully address social issues such as historical and current social discrimination and health outcomes. So my epilogue, I started with a prologue and I'm ending with my epilogue. History matters. It really does matter. The fact that we are generations post historical trauma and discrimination does not mean that we have ended the effects. In stratified society, health is intricately related to issues of human and gender equality, as well as to structural barriers that provoke and maintain inequalities. Effective prevention and intervention will need transdisciplinary approaches that acknowledge and address the social and systemic factors that give rise to drug use and AIDS risk for socially marginalized groups worldwide. So what did I find out when Dr. Friedman asked me, who am I? Well, I found out that I am a transdisciplinary scientist. I didn't know it at the time, and nobody had a word really for what it was I was trying to do. To acknowledge the fact that I was trying to cross boundaries and utilize the expertise of all disciplines to improve health outcomes for members of secondary social groups worldwide. So I leave you with this quote from Einstein. Of all people, I didn't expect Einstein to be quite so socially conscious. But you cannot solve a problem with the same level of consciousness that created it. So I leave you with the thought that to successfully address HIV/AIDS, we must be willing to change our level of consciousness as unidisciplined researchers and embrace transdisciplinary approaches that foster more effective health policies and social change. So I thank you for giving me this opportunity to talk to you.